one of the leaders said, you as doctors, you are used to staying in AC rooms. You cannot sit for 10 minutes also fast for strike.
You are part of the Indian Medical Association. How do you look at money in healthcare practice?
To do one cesarean section in a government hospital, the government is spending 1.5 lakh rupees. And what is it giving under the schemes to the private hospital to do a cesarean section? It is just 9,000 to 12,000 rupees. Financial assistance is abundant in our country.
The new MBBS graduates will not get into these spaces because they would be competing with unqualified people. Private healthcare provides about 90% of the healthcare in this country.
Their spending on healthcare is 7% of the GDP.
Why we cannot bring a central legislation to prevent violence against doctors?
Most of the time you see that patients are very happy with your treatment. But when it comes to the billing counter, somebody else who has come to pay the bill, he starts the agitation. Taking off your autonomy to professional practice in this country, which is against the constitution of India.
What does a politician think?
Back in 1981, the central government called for a tender on enlisting the package amount for these procedures. The recent one of the schemes introduced by the government, the package amount for inguinal hernia is 34,000 rupees.
That doctor earning is bad or good?
The costing came for one single procedure was too high, and what we were charging was almost 10% of what we got. If you take Western world like NHS, if you take any hospital, any department, each department knows what is it costing them to do a cesarean section. So based on that, their next year budget is decided. But is that the same in our government sector? No.
Prior to 2015, sir, 2015-16, healthcare probably was a self-regulated industry in state of Karnataka. And then came 2017 when KPME Act was introduced. So there was a lot of confusion and lot of negativity around the implementation of KPME. So in unprecedented numbers, a lot of doctors came to the streets, and during that time there was a lot of anxiety and a concern regarding the autonomy of the healthcare practitioners. So we both were witness, and I was a witness to you fasting for 4 days continuously in Belagavi itself, where we are shooting the podcast. From then, what was your mindset when you chose to agitate against an act of a government?
2017 was not the new KPMA which came in. It was just the amendments to the original KPMA, which had been existing since 2007. But after 2015, that is when the changes started coming in. There were plans to bring in amendments to KPMA, and initially there were discussions going on between IMA, the doctors and the government. But unfortunately what happened is every dialogue was one-sided from the government. So the government, whenever there was a dialogue, they used to say yes, we will do. Then there was a committee headed by one of the Chief Justice, retired Chief Justice, who headed the committee to bring in proper changes balancing both the doctors as well as the KPMA regulations. But it so happened that the first agitation took place in Bangalore. After that, again this committee was formed and certain changes were brought in. But all of a sudden, this plan of agitation in Belgaum started in 2017 October. That is at IMA State Conference, which was hosted by my branch in Gadag. So exclusively hall discussion took place between the IMA office bearers and all the members who had come there on taking their opinion, what everybody feels from across the state about this law or the changes which is being brought. And I was witness to that. We had to go through those amendments, what are going to come and all. Then we had a closed door meeting of all the leaders, and I was also part of that. But it so happened that we had a hope that government is not going to get these amendments, at least few of them. But all of a sudden, just before the assembly, that was Belagavi, it was going to be passed in Belagavi, and we came to know that the draft is ready, and it was the original 2015 what changes, draconian changes the government wanted to bring. The same, without the considering the recommendation of the Chief Justice, retired Chief Justice recommendations, they never consider any of those points, and the original thing itself was getting passed in the assembly in Belagavi. That is when we planned that we should have an agitation in Belagavi. The then president and the state leaders, Dr. H.N. Ravindra was the state president that time, and the other leaders like Dr. Yoganand Reddy and all other associations like FANA and other KPME association was there. They all joined hands. Then venue was fixed, and the president, the then president, Dr. H.N. Ravindra, decided he is going on fast. It was him who said he will go on fast. Meanwhile, what was happening is every district was meeting their representatives. And I was also part of meeting many of the representatives across the state. And everywhere we went and met the politicians, irrespective of the party, they were that, no, what that time health minister was bringing it, Dr. Ramesh Kumar sir. Whatever he says is there is some truth in that. That is what they were telling, without trying to understand our difficulties, if this law is going to come. And at one point of time, somebody said, when I was also part of that and I was trying to explain them, one of the leaders said, you as doctors, you are used to staying in AC rooms. You cannot sit for 10 minutes also fast for strike. That sparked me. I was actually warned by few of the state leaders, you don't sit for fast. But I took it as a challenge, and believe me, even I was surprised. I don't even fast for any of the rituals or festivals. But I was also worried for the second day or so, whether how can I continue. But somehow it went on well. And it was a great experience.
So like what were those draconian things that you were thinking of? Like what actually triggered you to go for fast actually?
One was, there are around 8 to 10 points which were actually very significant. There was a separate grievance committee which will be formed it is still there. But the doctors had to personally go and stand in front of that committee for representation. And any of the patient charters could be one of the points of litigation. It is not just billing aspect, it is not just negligence aspect. Suppose a patient is made to wait for half an hour or 1 hour, he can get irritated and go and complain. Suppose the patient didn't feel, though doctor has talked to him well, he has asked him all the questions, if the patient didn't feel that I have not talked to him well, he can go and file. These are all silly patient charters were included in that. And if that was included, that was brought in, it was like a nightmare. And another point was price capping to private healthcare. Though later on when they were explaining, they were saying it is only for the schemes, but it was, the wordings used was capping of pricing for private establishments. And it is like taking off your autonomy to professional practice in this country, which is against the constitution of India.
So that was a very intense experience for you, sir. And then after that, I think you are part of the Indian Medical Association throughout your career. So you have taken a lot of initiatives from then. So those few points probably would have made you think that how you could change it and how I can contribute or how one could contribute to change these things. And that sense, then eventually everybody would feel that you should be in the place where you could make these changes, right?
Right. Actually what happened is, that was the initial step where we started reading. We hear a lot of laws, but we don't go into depth of any of the laws.
So for example, anytime the doctor gets confused, he starts reading, right?
Yeah. So we are used to, doctors, we are used to reading the medical literature rather than at least some of the laws which are concerned to us.
Yeah.
the Indian laws are made in such a way that there are loopholes to catch hold of the person, and there are loopholes to, in the act itself, there are loopholes to get out of it also.
Yeah.
So unless we go into the depth of these acts and laws, it is very difficult to lead a life in this country.
Yeah.
So it is better if it is concerning to my profession. I don't say you see other laws. At least those laws which are concerning to my profession, the regulations, all those things, if you are at least brush it out. If somebody comes and questions you, you will be able to answer him well or get out of it well. So that is where our profession is lacking. So that made me, that was the initial steps when I started reading on different acts, like KPME I read first. I could go thoroughly into that and understand what is there, what changes are going to come and how it is going to affect our practice, day-to-day practice. And after that fight, probably out of 10 points, 8 points we succeeded in getting through.
Yeah.
After that negotiation.
Yeah.
And another 2 also got relaxed when rules and regulations came in.
Yeah.
So, and there was proper representation also in further regulations to be made. Like earlier KPMA didn't have expert committees. The new amendments brought in 3 expert committees which totally regulates the private practice in Karnataka. Like there is an expert committee for fixing the infrastructure standards of the hospitals in Karnataka, in which there are government representatives, there is IMA representation, there is a private representation from tertiary level care of hospitals, there is a private doctor who is representing secondary level care of hospitals and primary also. So there are almost 4 to 5 private doctors in that committee, and it is the committee constituted by the government for 3 years. Similar way, standard treatment protocol is the second committee. Third committee is the price fixation for assurance schemes. So in every aspect of our private practice, there is representation from our private bodies. So that is a good thing.
So what made you to think of joining the Karnataka Medical Council, sir?
Again, after this KPMA hunger strike, after 6 months, the then state president, IMA state president, brought in a new concern that we have to have a connect with the society. So he said, I am going to walk from Bangalore to Nargund for Madaya Yojane. Nowhere concerned to professional.
Yeah.
So we all Gadag people supported him. He walked all the through. During that walk, I joined him for the walk from Tadas Cross to Nargund. So during that time, even then one of the members, Dr. Kanchi, was walking along with us, and he started telling me about KMC and how it is functioning, and there are elections due to come and all. Before that, we also had some differences about renewal issues and all, court cases were going on. We were going through that. So that is when, because I was already involved in national level medical legal standing committee, and we were conducting locked off workshops for our members to understand the intricacies of medical legal issues. It had been almost 1.5 years I was part of the medical legal standing committee in the national IMA. So that gave me more interest. That then I went through the KMR Act, what all it does, what it does. That brought me interest that once I am into the system, it is easier to bring in changes, educate, understand more what type of cases are going to come, what are the mistakes or how the case are adjudicated and where our doctors are failing in representing themselves. So by doing that, by educating our members on these points, litigations can come down. That is what I felt. So that made me step into the KMC elections. That was in 2020.
So now, what actually KMC or any medical council does, sir, actually?
Most of the medical councils, they are the first role of any medical council in the state is they are the registering body for all the medical professionals, allopathy, modern medicine practitioners. They are the registering body, and whom and which degrees are recognized, that is governed by NMC or the MCI previously. Now it is NMC. They give the schedule of colleges which are recognized and all that thing. Those graduates passing out from those are only registered here, and also the postgraduates, addition of degree. This is first part. Maintaining that registry, publishing that registry is all done by the State Medical Council. Next is regarding governing the medical ethics and conduct of the medical practitioners in the state. If there is any issues with the code of conduct or any issues with the medical ethics, those type of regulations we look after. There can be either a litigation from the patient side or the public side. Public we only take if there is a significant professional misconduct or some aspects of medical ethics is violated. But it also governs on certain cases of medical negligence, and as per the act only we are a quasi-judicial body and we function as per the civil procedure code. All that which is done in a civil court is done in Karnataka Medical Council.
So the patient can directly approach a Karnataka Medical Council?
Yes. So we get cases referred directly from the patients. Then we get referred cases from consumer court on the opinion of a case which is registered there. We get cases referred from civil court as well as high courts.
Okay. So now many times the patient, whenever he feels that there is a negligence has been committed, goes to the police station. He doesn't know where to go. So last episodes we have discussed at length about FIR being filed. So the police ultimately when something is like that comes to their not notice, they have to take some action, right? So do they approach the Karnataka Medical Council directly, or what is the procedure for that?
No, that is as per Mathew's case. The KPME Association and IMA together approached the DIG and they have formulated a SOP on what to be done when a complaint comes to a police station from a patient party, or they have kept a dead body in front of the hospital and agitating, what to be done. All that is mentioned in Mathew's case by the Supreme Court. Guidelines is there. Based on that, the Karnataka government DIG formulated a SOP what the police has to do. As per that, it is clearly mentioned that any district police, when they receive a complaint, they have to refer it to the district medical board constituted by, if there is a medical college, the director becomes the chairman of that board, and based on the type of case and the speciality of the case, he chooses some members of that group, medical board. Medical board keeps changing, but the chairman remains the same. So they will analyze the case and give an opinion within a span of 15 days to 30 days. It is similar to any criminal case where charge sheet is prepared. For charge sheet to be prepared, you need to have proper grounds.
Yeah.
So here also, as per Mathew's case, they say that there should be a gross negligence to say that the doctor is the culprit or there is his litigant. Litigation is there. So define that gross negligence, it cannot be defined. It can be situation based, place based, availability of resources, everything has to be looked after when you consider that. So that's why that district board will take care of those cases which has happened in that district. It cannot happen that cases happen in Gadag and a person sitting in Belagavi decides on that.
Yeah.
But what happened is, over a period of time, because Bangalore and certain areas, it becomes a huge area and the police department didn't know where to approach. For them, Karnataka Medical Council became an easy place to approach for this opinion.
Yeah.
But we as Karnataka Medical Council cannot opine. We have to educate. So for last almost 1.5 years, we are not taking any police opinions.
So when does the KMC come into the picture?
KMC comes into picture, as I told you, when a complaint directly comes from the patient or it is referred from any court or tribunal.
Okay.
Then only
the district board, when they find it some issue is there, then the charge sheet is filed through the
yes.
Police station.
And it goes to court.
It goes to the court and court might ask you to look into
Yes.
it.
Court again has different opinions.
Yeah.
It is how both the parties plead.
Yeah.
Like once it goes to the court, if the doctor's side pleads that I want an expert opinion on that, that time court can refer it to Karnataka Medical Council.
Yeah.
or they can call an independent expert on that case. Suppose the patient party also demands a expert opinion. That time also the court can refer the case to Karnataka Medical Council. So till our opinion comes, this case in this criminal proceedings or civil proceedings will be stayed.
So what is the situation now, sir? In terms of the volume of the cases that you are receiving?
As of now, the pending cases we have around probably around 200 cases, and every week we are getting more of on an average 2 or 3 new cases.
Like in our regular judiciary system, is it just getting clogged there and getting delayed?
No, earlier it was yes, because we don't sit every day as the regular courts or any tribunals. We have only on Saturdays the proceedings takes place, and earlier only 20-22 cases were heard. But after the new body has come in, we have made certain changes, and the number per week hearing has increased to 55 now. And we have divided the type of cases into 3 different types and made 3 different halls. So that
like 3, what are those 3, sir?
one is for the first hearing and the final arguments, the main hall is used.
Okay.
Second is simple filing of evidence and taking
It
the next
depends
day,
on the
marking
stage
of the case.
Yeah, okay.
The third hall is for cross examinations. Cross examination also takes some time.
Which are the predominant kind of cases that you are finding?
Yeah, in this regard, to understand the entire scenario of how the education takes place in KMC, I have proposed and we are taking up. I have taken the lead, and there are other members also who are ready to join the hand. I am taking up a project of reviewing and analyzing the previous 25 years final orders from the Karnataka Medical Council. If that comes out, it will be one of its kind in India, because we have multiple publications from British Medical Council, General Medical Council, Australian Medical Council. We have publications with that. But in India, not many councils or publications are not there. So if we complete that study, we will exactly know which specialty more cases are coming, what are the demography, which areas the cases are coming more. I can roughly say, but statistically, rightfully commenting will be very difficult. Now what we see is metropolitan, there are more number of cases. Peripheral, North Karnataka, a few cases.
What is the nature of the case, sir? Like present trend, I am asking.
They have been changing. One is the awareness of patients. With all the technology now, everything, still patients feel that the common complications, like a wound infection,
Okay.
which has not healed for months, they feel doctor has not done well.
Yeah.
That is one of the. Second is easy accessibility of doctors. We copy entire medical literature from Western world.
Yeah.
But what we have not been able to know, we as private practitioners or the government has not been able to do is the proper referral system in our place. We still have PHCs, we still have THC, Taluka hospitals, community health centers, district hospital. But you are also aware that a patient with simple headache directly comes to district hospital.
Goes to the neurosurgeon directly.
Yeah, I stepped on. He goes to neurosurgeon, gets all the tests, and then comes back to GP.
Yeah.
But that doesn't happen in Western world. So easy accessibility is one of the reasons, and lack of awareness in the public that this is a known complication. It can happen to anybody. This type of lack of awareness causes them to file an litigation. This is first thing. Second is, he sees me first, then he comes to you. If he is well educated, he will just grasp one small sentence from what you have said. He will think that, oh, aur madle kodor hing madidra. He did like this. This expression of yours, he will grasp and feel that I have done mistake. The first person has done a mistake and files a case. Without analyzing, without understanding that it is a known complication, and the first person also has advised him accordingly, but he was not satisfied, so he has gone to a second person. So this type of litigations are more. And professional grudges also happen. Now, slowly the trend is like doctor is complaining on doctor. Those things have started now.
So healthcare is a very scarce resource, sir, in the country. The doctors also are a scarce resource, but still you are saying that there is unlimited access to the doctors, and doctors for trivial symptoms also the patients are going to the super specialist for the treatment, and it is clogging the upper pyramid. So, what is the solution for this, sir?
The central government recently had asked opinions from the public on accessibility and affordability of healthcare in India. So it was a very good topic, and I also sent my note to the central government about that. If you compare the Western world or the neighboring countries to India, the healthcare is very accessible to the public. In a way, it is good. In a way, it is bad. Good in the sense you get faster treatment, faster diagnosis, and faster cure. Bad in the sense the out-of-pocket expenses on the patient is increasing. Like if I go with a headache to a neurosurgeon, I'll definitely have to get an MRI done or a CT done. Based on in spite of his clinical knowledge, everything, still I will have to get a CT MRI done.
Yeah.
And then find that nothing is there in CT MRI, and he will prescribe me some drugs. Then ultimately he will again come back to the GP or at his own local areas. So again some treatment changes happens. So there is more out-of-pocket expenses to majority of the population. And by doing this, easy accessibility is causing burden on the super specialists who are working. Whether it is tier 3, tier 2 cities also, they are overworked. You consider a district hospital also, which is considered to be a tertiary level care hospital for a government setup. The number of OPDs what they are seeing is enormous. For a simple one patient to listen to him, examine and counsel him for the further treatment or management, it will take at least 10 to 15 minutes, minimum of 10 to 15. Imagine a doctor works for 8 hours in a day. How many patients he can see in a day? So if you cut short that, patients are dissatisfied because counseling is not happening properly. They are dissatisfied that examination is not happening properly because of cutting short of the time. So by doing a structured referral system, primary, secondary, tertiary, as it is in, I know because of the population it is practically not possible, but over a period of time it has to be slowly implemented by the government as well as in private sector, I feel.
But if you see, sir, the most of the times the referring doctors to any tertiary care center are from Ayush specialties.
Right.
So GPs from allopathy, general practitioners or family medicine guys from the allopathy are almost non-existent.
Right.
I was told by a senior doctor in our previous podcast that in last 25 years there is not a single new GP in Belgaum city from the allopathy. So that is the scenario. So how are you going to bring in the referral network? Because we are to again depend on these Ayush or quacks also.
So we through state IMA have given representation to the medical education minister as well as to the state government on bringing back certain either if not MD general practitioner or a family medicine course, but at least a fellowship recognized through RGHS, so that certain sector of MBBS graduates who are not able to take postgraduate seats, they can do these fellowships and start practicing in periphery as general practitioners. This will improve the healthcare as well as affordability of the patients and the population at a large. In fact, IMA national level has a structured program called as CGP, College of General Practitioners. It's a structured program where educational material is given, training is given and exams are conducted. But only thing which is lacking in that course is the recognition by a recognized university. So slowly that is fading out. Now I have raised it in the national level also that it is high time that we get it recognized by one or the other universities so that people join these courses. So, it is the responsibility of the government as well as us to push in people for general practice. If you consider my father, who was a first physician to Gadag, I remember him saying some 4-5 years back that most of the practice what he has done is a GP, not as a physician, as a family physician. So, majority of the physicians now, general medicine physicians, are doing that. Though it might not be called as a general practitioner, it is few
More
practice
or
only
less,
diabetology.
yeah.
So, the more and more importance is given to GP, as you said, Ayush are referring, because they are practicing GP now.
Yeah.
They are more approachable. They are more easily accessible to a lot of families. That is why people believe them. That is what in your previous podcast even Vinay told the same thing. Their counseling skills, their approach, their accessibility is very easy. That is why they are flourishing and people believe them. And litigations against them are also less.
Yeah. So now, you said that all the allopathic doctors who are trained in universities which are recognized by NMCs will be registered in the State Medical Council.
Right.
So the State Medical Council will have an authority over these registered medical practitioners. Whenever they do something wrong, then the State Medical Council will intervene to set it right. The problem is that there is a lot of people who are doing quackery. And quacks actually are not under any ambit of any organization. So quackery is a health hazard, and definitely the citizens of this country deserves better. So does KMC have any authority to punish these people?
Yeah. After we came in and we took charge in KMC, there are few amendments which have come into action by the state government with our recommendations and approval. That earlier there was a small provision to take suo motu cases for quackery. But it was not specifically mentioned as quackery. But now it is clearly mentioned that KMC has an authority to file an FIR against suo motu FIR against a quackery or a quack. That is now there in the Act, and we have been doing that. As of now, we are not going in search of quacks, but based on the media reports or anybody complaining that this person is practicing without any registration, we have had a subcommittee called as MEIC committee, that is Clinical Establishment Inspection Committee, which goes on surprise visits to these places, takes record on all of what is happening there, and takes evidences, and then instructs the police or the concerned authorities like KPME and other things to register a FIR against these quacks. This is happening. In last probably 1.5 years, the MEIC committee has done excellent work. They have done inspections of almost 30 establishments, out of which probably 10 were practicing quackery. That is something significant. As of now, it is being referred to KPME because they have authority on non-registered establishments. In next coming days, probably we ourselves will register an FIR through the registrar of KMC.
Because unless there is a unclogging of space of these quacks, the new MBBS graduates will not get into these spaces because they would be competing with unqualified people, and as you said, they have better communication skills and they have more reach within the community, so they would always flourish.
I would not agree to this point because it is like whether it is egg or the hen first. It is like that. Why they creeped into the society is because there was lack of doctors. Now there is abundance of doctors. It is high time that importance is given to general practitioners by the government and by our own people, medical fraternity. Our own people don't recognize general practitioners.
Yeah.
So that should start. That should start from within first, then the government, then the public. I would not take otherwise. Considering public to take it first, it doesn't happen. Our own people should start recognizing. the general practitioners. If somebody is practicing at some place, recognize his work, appreciate it, so that he also knows, or try to educate him on when to refer the case. That is still not happening in our medical system. Sometime the central government started as integrated medicine, which is actually without proper guidelines. They just said integrated medicine is good, but without telling them when to refer this case, and just starting an integrated course was not right. So you should have clear-cut guidelines. Like if you consider Western world like UK and all, the GPs have clear-cut guidelines on when a patient of headache should be referred to a higher center, when he should be referred for a CT scan. There are clear-cut standard treatment protocols and guidelines, which is lacking in our country.
Yeah.
So if that is recognized by our own people and the government and the public, slowly they will vanish, because people will start approaching them rather than the other way around. So it is like unless they go, our people will not enter. I would not agree for that. Our people should start entering, our own people should start recognizing them, then only this thing will build.
So this is the understanding of a doctor. Okay. So but you have had enough and more interactions with bureaucrats
Yeah.
and politicians. What do they think? That doctor earning is bad or good? What do they think? Like basically, when you say general tendency, if you see that there is a negativity around it.
Yeah.
So what do they think? Like you just please let me know about what the politician thinks and what a bureaucrat thinks.
Yeah. This I got interested in costing in healthcare some 6-7 years back. That was when I started. When I was interested in joining one of these expert committees of the KPME, as I told you. So I thought we should do homework before I go into that committee. So we formed a subcommittee in IMA state branch and did a costing protocol. When I searched the literature, there were books related to that, published for India and abroad. We referred all that, and coincidentally I found a costing template published by the Central Clinical Establishment Act. That is a government publication. So considering that, we did costing for private. And to our surprise, the costing came for one single procedure was too high. And what we were charging was almost 10% of what we got, the cost. Then I thought probably I have done some mistake in costing. Then I went to Chhattisgarh for a Hospital Board of India, IMA's wing directors meet. There, 2-3 state people who had done costing presented their studies. And to our surprise, the same procedure, only 500 to 1000 rupees different, and the costing has come the same. So then I confirmed that whatever I have done is right. Then we tried to analyze how the government is seeing it. Then we started interacting with our own members. Our own members didn't accept it. When I started talking on costing, few of them commented, he talks only about money.
Yeah.
So a lot of such comments came. Then we started, we did some homework with the government costing.
Yeah.
As of today, if you take Western world, like NHS, if you take any hospital, any department, each department knows what is it costing them to do a cesarean section. They know. So based on that, their next year budget is decided. If they are doing 100 cases of cesarean this year, and each cesarean section is costing them this much, so their budget of the next year is decided on that. But is that the same in our government sector? No. Because if you ask the government, what is it costing them to do a cesarean section in a district hospital or a medical college teaching hospital, they don't know. I filed RTIs twice to the government, asking what is it costing you to do a lap appendectomy in a government district hospital, and what is it costing you to do a abdominal hysterectomy. The first reply came was 0. They said, we are not charging anything from the patient, so it is 0.
The cost is the cost borne by the hospital,
Yeah.
not paid by
They
the
are
patient.
spending some money, no?
Yeah,
They should know what they are spending it for. Then I gave them the protocol and said, please use this protocol and give. They said they gave it is an elaborate process and we cannot do and such things. Then after the AI thing came in, recently I was part of again the costing committee, wherein the previous principal secretary had called in a meeting to include IVF as one of the Ayushman Bharat schemes. And all of a sudden we see that they have fixed a pricing of 1.2 lakhs without any basis. I questioned him, on what basis you have come to a conclusion of 1.2 lakhs?
Yeah.
They had no answer. They just said, we have asked few people, they are happy with 1.2 lakhs, that's why we fixed. Then I significantly told him, I humbly told him, sir, there is a costing protocol published by the central government in the Central Clinical Establishment Act. Why can't we use that protocol and do a proper costing for IVF? Because this is the new package which are including in schemes. Then he said, we are trying to do it, and he gave some answers. Then what I did was, I contacted different IVF association. We made a team, called in around 20 people, came in, Zoom platform. We discussed that if this is floated at 1.2 lakhs, getting it changed at a later date to higher amount is highly impossible. So it is now that you have to fight for it. So then I used AI, because these tables, there are around 8 to 10 tables in that protocol on doing the costing, and it is all in PDF. So you have to manually fill that. So what I did is I uploaded that to Claude and asked it to create a worksheet for me with all there are instructions also. Following that instruction, do a calculation ready spreadsheet for me. It gave me a beautiful spreadsheet. I have my own IVF center. I gave it to my administrators and said, fill in all the fields in that. Like what is the salary, what is the electricity, everything has to be filled. What is the rent? And considering last 3-4 patients, how much they have spent on medications and other things, those fields have to be filled. To our surprise, the moment that was filled, the exact package which came, that is around 3.5 lakhs, is the actual cost which a patient will incur or the center will incur in giving an IVF package. And to our surprise, last 10 cases, the total amount spent by a patient was 3.5 lakhs. So it is same. So the costing protocol is right. Then I gave that spreadsheet to all the members of that IVF association and said, you ask your administrators to feed it. Once we get different readings, we will calculate a median and then present it to the government with a proper scientific basis. So that process is going on. Same way, I have been telling the government that through these committees, use this protocol, use this technology, do a costing for your own district hospital, publish it. When it comes out, we are ready to accept 40% of that cost what you are incurring at government hospital. You will not believe, to do one cesarean section in a government hospital, the government is spending 1.5 lakh rupees. And what is it giving under the schemes to the private hospital to do a cesarean section? It is just 9,000 to 12,000 rupees.
So where is the bias, sir? Why these people are biased against private healthcare, whereas private healthcare provides about 90% of the healthcare in this country?
So, going in depth of why the government is not trying to implement, not trying to do this, because there are a number of business schools, business people who are ready to finance institutes, who are ready to do this exercise for us.
Yeah.
Why the government is not taking a step is because everything boils down to the government spending on healthcare in our country. If you consider our neighboring countries like Thailand, Sri Lanka, Bhutan, small state, I am giving examples of smaller countries. Their spending on healthcare is 7% of the GDP, whereas our country is still at 1.5 to 1.7. Though the last 2 budgets, the central government has said 2%, but what they have done eye-washing is, they have clubbed sanitation also in healthcare and said 2.2%. Whereas the spending for healthcare is still 1.5 to 1.7%. So it has been repeatedly our National IMA has been approaching the government and telling, we don't say that all of a sudden you increase it to 5%. At least aim to reach there. Next, say 2030 or 35, you aim to reach by 5%. Every year you increase by 0.5 to 1%. Then only the government health sector will improve. Otherwise, it is very difficult.
I think they are testing the bottom, sir, where how much lower you can go.
And
They're trying to see, like cataract surgeries, they want to get it done in 2,000, 3,000 rupees. Hernia surgeries, they want to get it done in 8,000 rupees. So now I think what I wanted to ask you the same thing, like what does a bureaucrat thinks who is not a medico? What does a politician think who is not? Probably they will announce something and they will transfer the onus on to the doctors.
For this, we had a beautiful session in Bangalore wherein a ex-Union Health Secretary had come. I can take her name also, Sujata Rao, a nice lady from Andhra Pradesh. She's very good and she has served a good term in central level. She beautifully, she's a bureaucrat, but tried to analyze the entire situation, and she said how government, all these projects function. Like there is a new thing what a government or a leader or a minister wants to implement, some project or a scheme. So they will have some idea from the public or some other country, they want to implement it. And they give the bureaucrats a timeline. Say August 15th is coming in next month, or say in 2 months, I want to announce it on August 15th. Where is the time given to the bureaucrats to plan it? No time. So meanwhile, if they have to take opinions from the private sector, hardly it is impossible. So what they do is copy paste.
From where?
From either the Western world or, see, now if you come to the costing, how are the costs revised under the scheme? What is the reference value they are having? They don't have any reference value. The only reference value what they consider for any scheme packages is the CGHS rate. Then I went and asked the same person, was then that time long back Union Secretary, I asked where from the CGHS rates came in. For which every scheme they tell CGHS, we have increased 10% to CGHS, we have increased 20% to CGHS rates. From where did the CGHS rate came? To my surprise, they told back in 1981, the central government called for a tender on enlisting the package amount for these procedures. And L1 was chosen based on that. It was never done by scientific methods. So whatever CGHS rates and the package terminologies have never been changed. There are few packages, you will be surprised. Even today when any new scheme is implemented, the same package is taken, only the numbers are changed. 5% is increased based on the place, tier 1, tier 2, tier 3 city. Like to give a simple example, I have given it to the government expert committees also. A splenectomy, where a spleen is removed from the body, it is a highly skilled procedure and risk involved. Blood transfusion is needed. Patient might stay in ICU for 1 or 2 days, and total stay in the hospital, even if it is laparoscopy or open, patient might stay for 4 to 5 days. This is the procedure of that procedure. Then another procedure is inguinal hernia, where any general surgeon who is a beginner also can do that surgery. It's a simple procedure. Stay of the patient is 2 to 3 days. No complications, no ICU stay, nothing. In the recent one of the schemes introduced by the government, the package amount for inguinal hernia is 34,000 rupees. Whereas for splenectomy, it is 24,000 rupees. So there are a lot of such disparities which are there in the packages, which is because of the hurry, even the bureaucrats or the officials, they just copy paste and increase it by 5%, increase it by 10%. So that is where we are failing.
Yeah.
It is high time that all those package, even the terminologies of the package, like somewhere it was written, a lump in the left breast is 8,000 rupees, lump in the removal of breast in the right breast is 6,000 rupees. Lump is same on both the breasts. Why is the difference? Without analyzing or putting their mind, these things are implemented. And later on, and there is no consultation which is happening with the expert body or the group of doctors who are interested in doing this work. And it is implemented, and later on we start fighting for years together in changing this.
Yeah. So now we have come to know that there is a lack of scientific understanding of costing in medical care. So how do you assess these things, and how do you want to bring in the changes? Because there is an element of human bias involved. There is an element of the government unwilling to invest into the healthcare sector, increasing in the budget. But then they already quite well know that the cost what they are trying to give to with respect to the schemes and all is quite less, but they still are talking about capping, sir.
Yeah. With respect to the awareness of cost involved in the healthcare, the educating the entire population with what is it going to cost me to do a procedure is very difficult unless the government steps in. For that, I remember in one of the podcasts, one of our leaders, state IMA leaders, and said that the government should start giving bills to every patient who is getting treated at a government hospital. Though they might not charge it, let them show it as zero, discounted. Even we do some amount of charity, or we generate bills for our own relatives if they are getting treated in my hospital. I generate a bill. If the bill is 50,000, I show it as discounted 50,000 and show it zero. Similar way, unless the government starts billing the patients which they are treating in government hospital, give them a bill, the patients have that in their hand, that becomes a reference value for the cost involved in the healthcare. So this is a process. So government cannot say, I am charging only 10 rupees for a room or a bed. It has to have a proper costing.
That's not
because
true.
they will have to, if they generate a bill, they will have to undergo an audit, financial audit, which will mismatch. So the auditors will not accept it. The finance department will not accept it. So if that falls into place, the public will naturally get aware that this is the reference value. Like if suppose tomorrow the costing comes out for a cesarean section in a government hospital to be 60,000 or somewhat. So if the government starts giving a bill of 60,000 to a cesarean patient which is getting discharged from a government hospital, and it is shown as zero, the patients will also get aware that government is spending 60,000 on me to do a cesarean section in a government hospital. So tomorrow he goes to a private hospital where the billing is done for 35,000-40,000 rupees, he will feel it is less.
Yeah.
And if any hospital is charging 70,000-75,000, he knows exactly how much more charging they are charging and why they are charging. He will try to analyze. Next comes the capping. So because of this publicity that private hospitals are charging more without knowing the reference value, this bias has evolved over a period of time. Whether it is in the common public, whether it is in the bureaucrats, whether it is in the politicians, or to some extent even in the judicial system. They see that private hospitals are overcharging. But if you compare the cost as compared to Western world, the equipment is same, the cost of the equipment is same, the doctor's salary almost is same.
Quite less, sir.
Less when compared to Western world. Everything is same. Why is the cost almost 3 times or 4 times more than the cost in India? And why is medical tourism booming in India is because of that. Because first is waiting period in Western world. To get a simple knee replacement, they have to wait years together. And the cost involved to get it done in a private hospital is almost 4 to 10 times more than what is being done in India. So that is why people come, travel. My own cousin who is a doctor who wanted to get a root canal done in Australia, it costed him 3.5 lakhs. He called me and asked how much it is charged in India. I told him Probably it is around 15 to 20,000 altogether, and for you, probably because you are a doctor, it will be done free of cost. So his flight cost was 60,000 rupees. He came here, stayed for 10 days, enjoyed his life for 10 days, got treatment done, and went back. Altogether, his spent was 75,000 rupees. So that is that. Not every citizen will know about this, unless government steps in, media steps in. There is a huge, and everything boils down to the healthcare costing, the spending of government on healthcare, the whatever percentage of GDP I told. Unless that is increasing, this is not going to change. And over that, because somebody filed a case in Supreme Court, some organizations, NGOs and some organizations filed a case that the private hospitals are charging heavily and out-of-pocket expenditure is increasing in India without understanding the intricacies of the medical network or the system. I told you, there is no proper referral system. That is also one of the reasons. Easy accessibility and affordability is one of the reasons for out-of-pocket expenditure. Without understanding that, case was filed. Hearing is still going on. A lot of interested parties like IMA, insurance companies, all have pleaded in that. Private hospital associations, all have pleaded in that case. And probably judgment is due to come in another next 5 to 6 months.
Regarding the
capping of pricing for private healthcare.
Yeah.
And it is against the constitution if it is being done. And it all boils down to one clause in the Central Clinical Establishment Act, where
I think, sir, I run a small hospital. I have been practicing for last 10 years as a surgeon. I think every one of us should sit in our own hospital. Do not have to worry about what the doctor, what the government thinks, what the public thinks. I think every one of us have to do what is called as COGS, cost of the goods sold, like cost of the services sold. And we have to have a realistic number. Otherwise, what is happening for a smaller hospital nowadays is that we also don't know. We are on a price war mission. Like if somebody is charging 10,000, I'll do it for 5,000. He is charging for 5,000, I'll do it for 2,000. So now, eventually, this will lead to a kind of annihilation of the smaller hospitals. Because if you are in the price war and the government is also making you feel that whatever you are charging is more and we are going to cap you even if you charge less also. So a day will come when small hospitals will start getting closer, and that trend is already started. So what is your solution? What do you want to say about that?
We try to educate our members. I as an individual, as also through the association, I started giving talks on healthcare costing in different branches. I try to educate our own members. See, sitting in place like Belagavi or Gadag, we easily comment on what they are charging in corporate hospitals, and our own members talk about that, say that yes, hugely they are charging, without understanding the intricacies of their costing. But I have sat with few of the corporate hospitals during COVID. I have sat along with them and understood how they do the costing.
Yeah.
They have the entire table in front of them. Every year it is revised.
Yeah.
How many of we as small hospitals revise our rates every year? We do it in our hospital. It is a standard. We revise our rates. We change the display, what has to be done as per the KPME. We change it every year. It hardly costs us to change that display. But many of the small hospitals don't do that. I am not saying suddenly you increase from 10,000, if you are charging this year 10,000, suddenly you increase it to 20,000. At least small increments. Just to give my example, when I started my practice in 2010, I was doing lap appendectomy for 10 to 12,000 rupees. It's been 15 years. Now my charges are nearing around 28 to 30,000 rupees. My hospital bill. Because there is recurring cost involved in running the hospitals, the expenses, the staff increase. See, when it comes to increment in staffs, we are giving. When it comes to government implementing minimal wages to the staff, we are
Sir, medical equipment, sir.
Medical equipments. AMCs, CMCs. It is a huge burden which is happening for bigger hospitals, small and medium hospitals also in the present era. So considering all that, government never considers that. If you go to any district hospital or government hospital, if you go to the basement, there are n number of equipments which are lying vacant, unused or used only for some period of time, and then a new machine comes in. So they have the government doesn't have the concept of AMC. So if something goes wrong, a new is bought, or it is kept idle. That is the concept. That has to change. That has to change in government. Just to give you an example of Sri Lanka, we were in talks with the government for a PPP model for dialysis. It became so easy for me to give them a costing and proposal of what if I have to do a PPP model with the Sri Lankan government. It became very easy for me to do the calculation, because they exactly said this is what it is costing us to do a dialysis. You will be surprised. Today's scheme dialysis cost given to a private hospital to do a dialysis per session is around 900 rupees and around 1000 to 1500 to a PPP model in India. Whereas the government spending on one session of dialysis in Sri Lanka is around 20 to 22,000 rupees. Nowhere comparable. It's our adjacent neighboring country. But they have the proper data on what they are spending, how they are spending. And considering the bias, what you said with the bureaucrats, the nature of functioning of, I won't speak of other departments, especially healthcare, because I have been in interaction with the government. We were invited to discuss about these programs with the government, additional secretary. All the rankings from principal secretary to additional secretary and other secretaries in the health department are doctors who have served as directors of a college or a hospital. They have been uplifted to this secretary level. So they understand the intricacies of healthcare system. Whereas an IAS officers in India, administrative posts, though they might have read so many things, but the ground reality and the ground problems what the department are facing are not reaching them in a proper manner, and that is where the expert committees came in. But unfortunately, for last not many meetings have happened about this expert committee. So again the government is lagging behind. We have been kept on telling the new ministers who are come, even the present minister has said that we'll try to revamp those expert committees so that things fall in place. We are hoping for the best.
Has KPME delivered what it wanted to deliver, sir, in last 10 years? Sorry, last 20 years.
Yeah, 2007 was the first KPME which was introduced. I would say 50-50. To some extent, yes. But the majority, what was intended in these amendments in 2017, many of them are still lagging behind. And we have kept on telling the various ministers and the officials who keep changing, we kept on telling them how we can improvise this system and simplify it. Many of them have happened because of the steps IMA has taken in collaborating with these officials and negotiating with them at different levels. To give one example, the renewal part of the KPMA, initially the renewal used to happen similar to the registration. Like when you are registering a new establishment, you have to give a lot of documents. So 10 or 20 documents have to be submitted to the KPMA, DHO office. And the same documents after 5 years, you have to again submit all those documents which are not necessary, which are a proof of your residence and other things, the occupancy certificates and other things, trade license. So 80% of those duplication of those documents were removed only because of the intervention of IMA and collaborating and discussing in a healthy manner with these officials. And that happened only because of the efforts of IMA and other few organizations, private hospitals. Similar way, recently because of lot of Supreme Court judgments and other things, fire thing had become a significant problem for getting renewals. It so happened that while formulating the regulations, it was mentioned that all establishments should have NOC from the fire department. It was made in a hurry because of the Supreme Court judgment, without understanding the nuisances and the problems and the practical issues what private hospitals are there in our state. Without understanding that, this was implemented. And what happens is, our members also, without approaching the association, like I would like to give again one of the examples of Western world. If you take Australian Medical Association, it is a strong body. Whenever a new policy is implemented, unless there is a consultation with that medical body or the Australian Medical Association, no policies are floated. Whereas here it is all divide and rule. There are a lot of multiple small associations, and the government also had taken advantage of this. Only a small association is called for meeting and it is passed, without knowing the deeper intricacies of smaller and medium hospitals. So what happened with fire thing was, NOC was announced for all the establishments without understanding. See, there are lot of small clinics. If you go to Hubli, there is a Eureka Tower. In the center of the city, there is a Eureka Tower, multi-storied building. There are not less than 50 to 60 small clinics in that building with separate registrations under KPME. Imagine each clinic going and approaching fire department to give an NOC. Does the fire department have a regulation to give for an individual part of that building? No. So they never consulted the fire department before announcing this NOC. So if they have to apply for NOC, the fire department, based on its regulation, has to give for the entire building. So who is going to get the NOC for that building? It is the owner of the building, not the clinic person. So it is getting delayed. He will not get an NOC, he will not get renewed. If his renewal expires, he is a quack now. Without registration, he is practicing. So these are multiple factors, and we kept on negotiating and discussing with the health department. And ultimately, because of intervention of few doctors who have become representatives to the assembly, like Kudalgi MLA, Srinivas is an ophthalmologist. He took special interest over last 6 months. We had given multiple representations. We had explained multiple times to the government about these problems. But because he took interest, he could organize a meeting, combined meeting of departments. That is again one of the problems in our governments, whether it is central government or state government. Coordination between the departments is lacking, and getting them on one platform to discuss intricate problems is very difficult. So here in fire thing, the member was successful enough in bringing both the ministers on one platform, their department people on one platform, and invited all of us, representatives from IMA, FANA, KPMA, all association people came in. We discussed our problems, they gave some solutions, we gave them solutions. Collectively, one concrete thing came out, and it has come out now as an order. Now we have clear-cut guidelines on who should take the clearance certificate, who should take an NOC, who should approach the fire department, and what are the guidelines for an existing building which is less than 21 meters. Earlier, every district was interpreting the NBC guidelines on their own. So now there is a clear-cut guidelines, and even the fees, everything was revised for the healthcare establishments. And that is one of the examples which shows, if we as a private sector work closely with the government and try to explain our problems and they listen to us, healthcare provider as a whole, whether it is government or private, will be very beneficial for the public at large. It should be always win-win situation for both. If somebody is totally banging on you, you should have this, you should have that, I'll get fed up one day and I'll stop my hospital. Who is at loss? I might go somewhere, I might run away to abroad, lead a good life. I'll be happy. But if such small and medium hospitals are vanishing day by day, who is at loss? It is the common public, not the government, not the doctor. It is the common public which is getting affected. That has to be convinced to the government to implement certain rules and regulations.
Seeing the spectrum of things happening from agitation to the policymakers, sir. So, how much of things that you would like to change has changed, and what is your next mission? Like, what you would like to see as a change in terms of policies and other things?
As far as the functioning of the government, if we see, this is an ongoing process. There are new policies which are going to come. Unless and until the government takes us into confidence while bringing in, I told you the example of Australian government or British, UK, where the association is called for when the policies are made. If that is not happening, this is an ongoing process. A new policy comes, we find the intricacies, we find the problems in implementing it, and we keep negotiating with the government, you bring in this change. If it is a smaller change, government also can do it. If it is a significant change, again it has to go back to the assembly, get it passed, and then it has to be implemented. It is a significant. So there is a significant change which is required, and for that, in every government meeting where minister comes, the one and the only point I stress on is activating these 3 expert committees, because everything boils down to that. See, for example, to tell you about COVID is, when COVID came in, they formed a new guidelines committee. Without, see, government wants to take action on establishment based on KPME, but while forming policies, they don't want to consider that committee. So, use the KPMA in both ways, where representation from all sectors of the private sector and government sector are there, where they can have discussions, collaboration. There is a provision in that where it says experts can be invited of that field. For example, fire thing. Fire is an requisite for an infrastructure. So, there is an expert committee on infrastructure guidelines. So, this should have been taken in expert committee of infrastructure. Discussion should have happened. Experts from fire department and other departments should have been invited. They should have discussed, and combinedly they should have come with the guidelines, which should go to the government for clearance. This is how a policy should float in with respect to private establishments. But it is not happening. In COVID, there is a separate treatment. For treatment guidelines, there is a separate expert committee which has floated. Whereas there is an expert committee already existing in KPMA to set in standard treatment protocols. Whether it is COVID, whether it is appendix, this is the committee which has to be considered. When it came to costing in COVID, I kept on telling the government officials, why is it not that expert committee is consulted in this aspect? I openly asked in a video conferencing call. That time secretary said, no, that is only for assurance scheme. Even here also government is reimbursing this amount. This is also similar to a scheme only. And through some means we devised some costing for COVID treatment. The cost we came out, me, few doctors from Apollo, few doctors from Ramaya, all sat together and came, considering everything. What if certain percentage of staff get unwell? We have to incur the cost of their treatment also into this. Considering all the PP kits, drugs, everything, we came to a conclusion that basic price for treating one COVID patient was 11,500 rupees. Without the special drugs or special investigation like interleukin and other things, the basic package should be 11,500. The file went to finance department. Finance department, how it calculates is, it projects the budget. Suppose these many patients get unwell and these many patients will have to reimburse the amount to the private sector if they get admitted in private. This will be the expenses we'll have to incur. It was not in the position to spend that much money. So they said 50%, 5,200 was fixed. So that is how government is.
Thank you so much, sir. Thank you so much for your lot of insights that you gave regarding your journey from agitation to implementation of policies. With that respect, I would like to say that on a personal note that we have a long way to go and a great deal of responsibilities on our shoulders to deliver these policies, bring in these changes in our own individual levels, and also try to bring in those changes in incremental with lot of patience at a higher level, which I think you are doing it, and I should congratulate you and thank you personally for doing it, because in our day-to-day routine, taking out time for the profession itself is not seen as something very productive and rewarding, but you are doing it which will have a longer impact for the next generations. Thank you so much for doing that, sir. Thank you for the sharing your opinions and ideas with us today. Thank you so much, sir.
Thank you once again for having me here, and it was a very good, fruitful discussion. Congratulations to you for bringing this podcast live to educate our own members. Similarly, one last note to all the young doctors. I know in the initial days of your practice, you are busy establishing your own practices. But at least after say 2 to 3 years, once you are into the practice, give some part of your time for the association type of activities, so that younger generation, if they come, they will have more ideas with the guidance of the seniors in that association, and in collaboration and negotiation with the government, significant changes to the medical fraternity and to the public at large, bringing in affordable and quality healthcare to the society can be possible. Thank you. Thank you once again.
Thank you so much, sir.